can stick to the time so that we have the prayer time. Very important topic, breast cancer management during pregnancy and all the fertility issues. And for that, I would like to present Professor Ann Partridge from Dana-Farber Medical Cancer Institute to share with us her valuable experience. Thank you very much.
Thank you and good morning. And obviously these are related topics, but somewhat distinct. So I'm going to start talking about the breast cancer management during pregnancy, and then the second half of the talk I'll focus on fertility issues. And of course, patients may overlap for both of these issues. First, a little epidemiology. At least in the U.S., breast cancer during pregnancy is the most common malignancy observed during pregnancy, although you can see that thyroid cancer is right up there as well as the others listed. So, and it's expected about 3.7 per 100,000, which translates to about 1 in 3,000 pregnancies. Treating breast cancer in pregnancy poses, as we all know who treat patients with breast cancer and see the young patients, complex therapeutic and ethical challenges. And to further compound that, there's a lack of randomized data, of course, to support safety and efficacy of standard regimens. You would expect that it would work, a regimen, but of course it's about safety, and the safety is not only for the mother, but for the fetus. Of course, should this be a wanted child. Most data that guide our decisions in this setting are from case reports, observational cohorts, and retrospective analyses, and we're all familiar with the biases of publication of such reports in the literature, and thus the availability, and also, of course, a lot of us can't help but treat in this setting based on anecdote, which, of course, is not a great driver of clinical care. It also requires to treat these patients individually modifying standard treatment algorithms because of the issue of fetal teratogenesis all the way through to intrauterine growth delay, as well as potential complications peripartum, in order to create the most effective treatment plan for the pregnant patient and minimize the toxicity for the fetus. So we spend a lot of time historically worrying about side effects for the mother, and here we have an extra patient and a very vulnerable patient in the fetus. And thus, the punchline for all of this is you can't do this alone, and anytime one is treating a pregnant patient, getting a multidisciplinary team involved is clearly the way to go. Not just the oncologist and the obstetrics team, which we usually reach for a high-risk team member or a maternal fetal medicine doctor, but also the social workers, bringing the family into the team, and any other relevant providers, depending on the stage, including the surgeons, the radiation docs. Well, let's shift gears to how do these patients present. Well, first, just like breast cancer, and all patients in breast cancer and young women in particular, the presentation can be very variable. The problem here is that a breast mass or swelling in the breast can be confused with the normal sequelae of pregnancy, especially for a woman who's never been pregnant before. And these women can have substantial delays in diagnosis, even though they are being seen by medical providers generally in the prenatal period. The swelling can be confused, the nipple discharge might not be worrisome, and so being vigilant about breast health in that setting is complicated because of the confounding by just pregnancy changes, especially in someone who's never had one. And then once there's concern enough to do workup, the diagnosis and staging can be difficult because of the risks and the tendency and the appropriate tendency to try to avoid unnecessary exposure, in particular to radiation. We do know from available data and extrapolation in this setting and in other pregnancy complicated settings, not just cancer, that ultrasound, of course, is safe. MRI without GAD is generally felt to be safe at this point. If someone's going to undergo a chest x-ray or a mammogram, we try to have shielding, but in general it's okay to do the mammogram if it's necessary. Of course, not always so necessary in these young patients because they often have the dense breast and it's not going to help that much, but we tend to do it. We try to avoid PET CTs, bone scans, and CT scans to avoid unnecessary exposure. And then, of course, if intensive staging is needed, we often delay until after delivery, and that can provide some reassurance after delivery when someone's been treated, but it can also pose some complex problems when you find something and you've already kind of committed that person to chemotherapy that you otherwise might not have given them if you hadn't known that they had metastatic disease, at least at that point. And of course, let me just see if I can close this. You want to make a good diagnosis, just like in a patient who isn't pregnant, and so standard approaches to trying to diagnose, including core biopsy, to get not only it's a malignancy, but the histology they're critical and safe. The good news is when these patients have been looked at in terms of how they do in the long run, it used to be that we thought this was just the worst disease possible, and basically, when the studies have gotten better over time and we've been comparing apples to apples and matching patients appropriately based on pathologic features, the pathologic features appear similar to age-matched non-pregnant breast cancer patients. Of course, there's an enrichment for hormone receptor negative and high-grade tumors, but if you were here yesterday and saw my talk and perhaps seen your clinics, young women are more likely to have hormone receptor negative and high-grade tumors if they're going to get breast cancer than older women. And when controlling for age and stage, the prognosis of pregnancy, breast cancer diagnosed during pregnancy does not, at least in this day and age, if a patient is treated appropriately, appear to be compromised in terms of how they do in the long run. The prognosis and tumor biology of postpartum breast cancer, or the more classically termed breast cancer associated, or pregnancy associated breast cancer, and I want to make this distinction. There's breast cancer during pregnancy, and that's what we're talking about today, but there's also breast cancer, or pregnancy associated breast cancer, which is more classic. They get confused in the literature and people throw the terms around. But these days, most of us are referring to pregnancy-associated breast cancer as breast cancer that occurs actually very subsequent to the pregnancy, within, after the peripartum period, perhaps within the year out to 5 years, because there are some unique concerns about the biology of those cancers after the pregnancy and the involution of the breasts and or the nursing changes that might occur in a breast. So biologically, we think of these as distinct, and of course, they're different in terms of how you have to manage them. Pregnancy associated after a pregnancy, the fertility issues may be important, but you can treat that person like any other person because you're not worried about a fetus at that point. So I just want to make that distinction. So treating breast cancer during pregnancy, here are the possible choices, and I think it's important to really think these through with any given patient. And I will tell you, as I was preparing for this lecture, I got a call from a patient of mine this past Friday. She's 44 years old. She's 7 years out from a HER2-positive breast cancer, multi-node positive, doing fabulously. Got Herceptin early on, and she's 44. She was taking her extended tamoxifen because we discussed that. When I had first diagnosed her, she had 2 kids. She wanted one more, but she dealt with that. She's pregnant. So, the first question is, what do you want to do? And I think one of the most important things, not a new diagnosis, so a little bit different than what we're talking about, but I think, one of the first things we have to all work with on our patients is, do they want this pregnancy? And that's the one on the bottom. It's not a fun thing to talk to patients about, and in some cultures it's not remotely an acceptable alternative. But where it is something that people think about, it's a hard conversation to have, I can tell you, because I had it last Friday. The other options for patients pregnant and having breast cancer at the time is to defer some or all of the cancer therapies. And some women, if they're going to get diagnosed with breast cancer during pregnancy, are lucky, not that they got breast cancer, but that they're diagnosed right at the end of the pregnancy. So while it's alarming and it's upsetting, generally breast cancer is not an emergency. It's not leukemia. You don't have to treat right then usually, and often you can kind of set people up for surgery or start the ball rolling for the appointments to start treatment and get them all ready, but wait until delivery. And that's very, obviously one of the best situations in terms of trying to treat a patient. Usually try and get the treatment started soon after delivery. Initiating during pregnancy is obviously what we're going to focus on today, and then of course you can make no modifications to standard treatment or modify therapy, either the timing and order of the surgery, systemic therapy, radiation, very tailored often, as well as the agent selection. But I think the key is to try and get women the best effective therapy and at the same time spare as much to the fetus as possible. So why are we even concerned about this? Well, I think we all know chemotherapy is a potential teratogen. Risks are related to the agents, the timing of the administration, and the dose of the therapy. And the potential risks to a human fetus include early effects, which are spontaneous abortion, teratogenesis, organ toxicity, intrauterine growth retardation, and low birth weight. And then oftentimes, sometimes we fail to think about, especially in someone who may go early to have their delivery, is the labor and delivery complications. And these include low blood counts as well as premature birth, which of course is not good for the fetus in general, especially if very early. And then there are the theoretical concerns about late effects. So does in utero exposure to chemotherapy increase a baby's chance, and then as that baby grows, of developing cancer themselves, independent of genetic issues? Doesn't appear to be the case, which is good. But we don't have great data on this. Gonadal dysfunction, infertility, retarded physical and neuropsych development, mutagenesis of their germline tissue, and teratogenicity going forward, and of course carcinogenesis of subsequent generations. We don't think there are huge signals in the data we have, and I'll show you some of that, but we don't have great data here, so these are all theoretical concerns. The good news is, at least in breast cancer, there are actually a number of major case series. You can see them listed here, and we have one from our institution as well, which I'll show you in a few minutes. But most standard regimens for common pregnancy-associated breast cancer appear to be, quote-unquote, safe to use in the second and third trimesters. And you can see the different rates of abnormalities seen. They're not zero. And, of course, pregnancy itself, especially as women age, is not a spectator sport. And so I always tell people when they ask me, is it safe for me to get pregnant? Is it safe for me to do this? Well, it's as safe as it's been, plus you're adding in some extra risks with the treatment. This is our series, which is not projecting as well as I would like. And all of our chemotherapy in 68 patients treated during chemotherapy of a series that we've recently put together from our multi-institutions. Were treated in the second and third trimester. All the patients received AC, and almost 10% received taxanes, and a small proportion received growth factor support with Neupogen because they were getting dose-dense therapy or substantial neutropenia or fever. And what we found amongst the 68 infants was that the weight and the Apgar scores were consistent with general population expectations, and of them, 3 had fetal abnormalities, about a 4.4% rate, and that was congruent with not too far off from general population estimates. There were more early deliveries than one would see generally in a normal population, and this may have downstream implications for the fetus, for the progeny, for the children, and we're following these patients. Well, what are the other management issues? And I'll briefly go through these. First, taxanes. It's been a long time. There are a lot of series and case reports of the taxanes, and they do appear to be acceptable when needed during pregnancy, especially Taxol, where there's more data, and this has been reported in other diseases as well. It also appears in other diseases, and therefore we're using it more in breast cancer, that filgrastim or GCSF is safe. Trastuzumab is actually completely contraindicated at this point because of of the early reports of oligohydramnios. However, subsequent to that, it's been looked at in the HERA trial because, of course, they gave her trastuzumab for 1 to 2 years in that study, and there were several pregnancies and no reported complications of the pregnancies in terms of oligohydramnios or other abnormalities. So fetal demise and or abnormality is not guaranteed after exposure to Herceptin or trastuzumab in utero. Tamoxifen has kind of a similar story in that there's been reports of a golden horse syndrome, which is a funky changes in the ears and eyes and development of the head, ambiguous genitalia, and yet hundreds of babies have been born after exposure to tamoxifen in utero. We've been using it for prevention for years. We've now, using it for adjuvant therapy in young women for years now. My patient is one example, so at least I could reassure her with that in the 100 or so patient series, many will not have any problem, at least ostensibly. Surgery is relatively safe with careful monitoring in pregnant patients. My high-risk maternal fetal medicine folks will say that it's okay in the first trimester as well, and that it really is about trying to avoid risk early on, because many pregnancies will end up in a miscarriage regardless of going through a breast cancer treatment surgery. And one of the reasons that we don't do surgery in the first trimester is not necessarily because the surgery increases that risk, although it might slightly. It's because people want to avoid that risk if you can avoid it. In the U.S., it's a big medical legal issue as well. Radiation, of course, is contraindicated because of concerns about causing teratogenesis. So in conclusion, breast cancer during pregnancy there's never going to be perfect safety data, and explicit conversations and a multidisciplinary team are very necessary to try and balance the therapeutic risks and the benefits for both the patient and the fetus. And this is a patient and her husband with a healthy baby boy who she was treated with 4 cycles of AC, and he looked pretty good and cute. So let's switch gears and focus on fertility, and I'll go through that in the next 4 minutes or less. Several years ago, after experiences in the clinic with young women coming in and this being a major issue, I collaborated with my team and the Young Survival Coalition based in New York, trying to ascertain how frequent are young women interested in fertility at diagnosis. And we ended up surveying over 600 young women who had a median age at diagnosis of 33 years old, and they were about a year or 2 out from diagnosis. And in that group, nearly 57% of these women reported substantial concern about fertility after treatment. And nearly 30% of them, and this was kind of scary, reported that fertility concerns had influenced their treatment decisions. So this isn't just something people are worried about. This is something where they're saying, oh, I'm not going to take that chemo, or maybe I won't take the full 5 years of tamoxifen. And so it could be compromising their outcomes, and we really need to start focusing on this. The other important thing, and why this was something that was worth studying over a decade ago, and why it hadn't really been thought about too much prior, was that it was increasing this problem because more and more women in our societies are deferring childbirth to get more educated, to start their careers off. And you can see the age of average first birth between 1970 and 2006 in several countries is dramatically different. The important part about that is that it also means that these women who may go on to try and have a pregnancy at 35 because they wanted to start their company, their ovaries are going down the tubes in terms of their oocyte production. And you can see the natural decline of oocytes with increasing age here. And I love that picture on the left where it's all these little oocytes and then there's like the lone, empty one. And we know that, at least from chemotherapy and hormonal therapy, that the risk of developing amenorrhea is related to age and treatment. You can see the dramatic curve, which parallels those curves with those eggs dropping off in the pictures at about age 35, the way that it goes slope up. Chemotherapy amenorrhea in particular we need to know, though, is a surrogate and an imperfect surrogate for menopause and infertility, and it may be permanent or temporary, so you're looking at point in time, and especially among the very young, they can revert back to being very fertile. As I said, my patient reverted back to obviously being pretty fertile, and she was already 44 and had gotten ACT and H and lots of tamoxifen. These are data that we've put together that emphasizes, again, the risk of amenorrhea, again, as a proxy for infertility by age and by treatment regimen. So it dramatically goes up with age. Once you're over age 40, it's much higher. And then the more alkylating agent, the higher the rates of infertility in some. This is just more recent data that we put together that shows that adding a taxane, making things dose dense, adding trastuzumab, there was no statistical difference, at least in our large series, from that in terms of premature menopause or CRA. Looking a little deeper, we looked at ovarian reserve in survivors compared to controls, and others have done this as well. And even in these women who are all menstruating, ovarian reserve does appear to be diminished in survivors compared to controls. ASCO has put together guidelines about this, and I put the arrow at the top, which basically, I'm going to fix it. I promise I'll only be about a minute and a half. Thank you. I put together the arrow at the top is we need to talk to our patients about this. This is an issue. It's going to remain an issue for these women if we don't talk about it early on and help them if we can, and if we think with them that it's appropriate to preserve fertility because they're older and they have high risk of becoming infertile with therapies. We need to discuss it. And then you can see at the bottom of the slide the available and experimental options. In 2012, oocyte cryopreservation prior to therapy became no longer experimental because the freeze-thaw process has gotten so much better. And I put ovarian suppression with one of the LHRH agonists now kind of in the middle. It was in the experimental area. That's based on more recent data from both Italian trial as well as the SWOG POEMS trial, which was just presented at ASCO, both of which were positive in terms of the ovarian suppression through chemotherapy being associated with safety first and foremost, as well as more preserved ovarian function markers at least, as well as more babies in the SWOG trial. And so this is pretty compelling, and I suspect the guidelines will likely change. There's a meta-analysis that's underway to try and make sense of all of these randomized trials of the ovarian suppression. So what about the risks of fertility preservation? Well, there's procedure risks. There are protocols now to use letrozole or tamoxifen to do the stimulation prior to someone going and getting their eggs harvested and perhaps doing IVF or freezing the oocytes. And it's not clear that letrozole or tamoxifen stimulation actually mitigate risk. There's some very short-term and small number safety data from Kutlik-Akte in New York, which I find reassuring, but I'm not sure that they really tell us that much with breast cancer outcomes usually requiring thousands of patients. The other issue we now know is that what is the risk of preventing menopause? Because we now know that not only retrospectively, but with the SOFT trial, suppressing ovaries may actually be good therapeutically for a patient, especially one with high-risk breast cancer. And so should we really be working to preserve their ovaries? I would argue that if they really want a pregnancy, then we have to weigh that. And then the risk of a pregnancy subsequently. These are data from Hatamazim study, which I think is the best and most well done to date, where they actually were really able to match pregnant patients with matched controls, 3 controls per pregnant patient, and they, for one of the first times, were able to account for hormone receptor status and all of the important other predictive and prognostic factors. And as you can see here, even in the ER-positive breast cancer with a long median follow-up, there was no difference. Those curves overlap between women who had pregnancy after breast cancer and matched controls. And so that's very reassuring for our patients. Of course, it's all retrospective, and it may suffer from the healthy mother bias, but usually I'm only recommending for patients to try and go on to get pregnant if they're healthy at that time. So hopefully they fit that mold. And early pregnancy in their data also, less than 2 years, was not associated with a woman doing worse than women who did not go on to have a pregnancy during that time frame. So in some, fertility after breast cancer, it's a very difficult issue for many young women. We need to talk about it, discuss it early in the course of their care. I think we need to acknowledge both for ourselves and for the patients the inherent tensions that exist between the desire to optimize breast cancer treatment and have future biologic children. There are choices. You can forego therapies. You can negotiate to take less endocrine therapy. But of course, we worry that taking less endocrine therapy will not get patients the benefits of endocrine therapy. We know that 5 years is better than 2 years of tamoxifen. That's been shown. We know 10 years is a little bit better. And patient preferences are critical here. This is a place where we actually have to kind of take our paternalism and put it on the shelf so we can help the patients to make the best decisions for them and have no regrets. Of course, we bring our knowledge, though, and our perspective. And much is known and much is still unknown about this area, so we need to support research in this area. And I'll end with what's a very exciting study where we are actually trying to answer some critical question here. This is called the POSITIVE trial, so we're really hoping the study will be positive. And this is a study where we are doing essentially, it's a phase 2 or observational cohort where we're going to follow algorithms. Women who want to have a pregnancy, and we all have these in our practice, these women who want to have a pregnancy, they were getting worked up when they were diagnosed, and they want to stop tamoxifen or the endocrine therapy early, and you say, we know that maybe it's okay to take breaks. We know from some studies that women who get pregnant after breast cancer actually do better than women who don't get pregnant. Breast cancer, especially ER-positive breast cancer, is a chronic issue. They're going to go out 10, 15 years and still have risk. So can we allow these women to get good therapy and at the same time complete their plans for life, which for many is including biologic children? And so this study is designed to study that question. And what we're going to do is women who want to have a baby will go into this study and interrupt their endocrine therapy at between 18 and 30 months. So it's early interruption, and then we're going to recommend they get back onto the therapy with no longer than a 2-year break, take as much hormonal therapy as they were recommended to take at the beginning, 5 to 10 years based on current recommendations, and then we're just going to follow them. And we've figured out the sample size such that we really think we'll be able to learn from this. I do believe this will be open at centers in your area because we're opening it all over the world. It's very exciting, and hopefully we'll learn for those patients the safety of doing this and learn about the efficacy of even becoming pregnant, because for some it can be difficult after all the treatment or and some of the endocrine, the endometrial issues. So I'll stop there, and thank you.
Thank you, Dr. N. Very impressive presentation, but for being late, 15 minutes beyond the scheduled time, sorry, no more question. Just to shift for the next presentation,